Hello, welcome to this session on person-centered care. Today we will be looking at non-adherence in asthma care. What is person-centered care? Why is it important? And how can we deliver person-centered care in asthma? We will also be looking at how we can integrate the multidisciplinary team to help patients and deliver person-centered care in asthma. So, what are we seeing in medicine today? We're seeing advances in technology, we're seeing advances in medicine, but sadly, adherence levels are still variable. Treatment adherence rates are highly variable, ranging from 0% to over 100%, depending on the condition, therapy, and methods used to measure adherence. So how does this relate to asthma? Respiratory disease in asthma. The World Health Organization estimated that more than 339 million people had asthma globally, and there were over 400,000 deaths due to asthma at global level in 2016. In the UK, over 8 million people, or approximately 12% of the population, have been diagnosed with asthma. Asthma accounts for between 2 and 3% of primary care consultations every year. There are over 600,000 hospital admissions and 200,000 bed days per year in the UK used for asthma. GINA reported over 50% of adults and children on long-term therapy for asthma fail to take their medication as directed at least part of the time. So let's explore non-adherence in more detail. So why do people non-adhere to their treatment? Do we all intend to non-adhere? Actually, non-adherence is a varied behaviour rather than a trait. Adherence rates vary between patients and within the same patient over time and across treatment. So if you can imagine an asthma patient who has good asthma control, they may no longer feel it's appropriate to take their treatment on a regular basis as they feel so well. In these instances, their regular treatment tails off. Most of us are non-adherent some of the time. I take medication on a regular basis, and I can quite readily admit that I am non-adherent. But we will look at why I don't adhere in a little while. Non-adherence may be the norm rather than the exception. We're going to go back to looking at what we call the information gap now. So, the myth is that providing more information about a therapy improves adherence. This is the information gap. But do we really think this is the case? If we look at this cartoon here, the information is quite clear. The person has been given clear instructions to put their mobile phone in the basket. The illustration has provided clear instructions. But do you actually think anyone is going to put their mobile phone into this basket? I doubt it very much. So let's look at the information gap. Professor Rob Horne looked at this in great detail at the University College of London. He looked at why there is an information gap and whether this actually improves adherence. So do we just need to give patients more information to change their behaviour? Well, information is definitely essential, but to enable adherence, we also need to give more information that may help with existing beliefs or even change beliefs. Just giving more information on its own does not guarantee engagement. We definitely need to discuss our patients' beliefs with them and find out what they want rather than what we want. So, why have previous interventions had such limited effects? Why just talking to our patient hasn't improved adherence to medication? Here we look at intentional and non-intentional or unintentional adherence. The blue circle looks at intentional non-adherence. And this is patients that decide they don't want to take their treatment or are not going to take the treatment. And this is very often because of their beliefs, their preferences, their perceptions of medication, and how they feel about having a chronic disease, for example. It may be that the person doesn't believe that they have asthma, therefore they do not need to take asthma treatment. They may have strong beliefs regarding the medication that they take. So if you can imagine a child, the parents may have strong beliefs about inhaled corticosteroids. They may have strong emotional feelings about giving their child medication on a regular basis. And because of these beliefs and their perceptions and how they feel may mean that they intend not to take treatment on a regular basis, or in the case of a child, may not intend to give their child regular medication. And this is where we need to work with the parents or the patient on understanding what their beliefs are so that we can help them change their behaviour. On the right hand side in this orange circle is definitely where I sit as a patient. I have unintentional non-adherence. I believe in my medication. I believe it will make me better, but sometimes I forget. Sometimes I'm busy and I think, oh dear, I've forgotten to take my medication. It's a bit too late now. That doesn't mean that I don't have the belief or the understanding of my medication. I believe it's going to help me, but sometimes I forget. And that's a non-intentional or unintentional non-adherent patient, in that they have beliefs in their treatment, but the practicalities of taking that treatment means that sometimes they non-adhere. And I think you will find that most people, even when they believe in their treatment, do not take their treatment every day as prescribed because things get in the way. And I want you to imagine a busy parent who is trying to look after young children. She's got to get them ready for school. She's got to get them up. She's got to feed them. They've all got to be at school on time. She's then got to rush off to work, do her job, come home, fetch the children, get their evening meal, get them ready for bed. And suddenly, actually, her looking after herself becomes the least important thing in her day. This doesn't mean she intends to not adhere to a treatment. It means that barriers get in the way of her taking her treatment regularly. And these are the patients we need to think about. And these are the patients we need to think about how can we help them take their treatment more effectively. Could it be that we have to change the way we expect this patient to take her treatment so that she can take it on a regular basis? Think about your elderly patients who are on multiple treatment regimes. How adherent do you think they are on a regular basis? Or are we making it just too difficult for them to take this treatment on a regular basis? And this is what we call unintentional non-adherence. Patients don't intend not to take their treatment. Things just get in the way. And these are probably the most difficult ones because you haven't got to change these patients' beliefs. You've got to change their behaviour, how they do things on a regular basis to allow them to take their treatment on a regular basis. So Gina looked at poor medication adherence in quite detail. And as you can see, they found that there were lots of factors contributing to poor adherence. So we'll start looking at medication regimes and factors. So things like difficulties using their inhaler, burdensome regimes, multiple times per day, multiple different inhalers. All of these things can make adherence difficult. These patients intended to take their treatment, but their treatment regime was too complicated for them, or they just couldn't use the inhalers that were given to them. Unintentional poor adherence. involved misunderstanding about the instructions of the medication that they needed to take, forgetfulness, they couldn't remember to take their treatment regularly. They didn't have a daily routine, so they just couldn't get into the right routine of taking treatment regularly. And cost was a big factor for patients. Do remember that asthma medications are not free like some other chronic diseases, so patients are having to pay for their treatment. And this is where you may want to talk about things like prepayment certificates to try and help your patient with the cost of their treatment. I can guarantee you if somebody is struggling with the cost of their treatment, they will always get their blue inhaler, but they may very often leave their other treatment at the pharmacy and ask the pharmacist not to dispense them. So do think about cost when you're adding more and more multiple treatments to asthma patients' regime. If you think about the stepwise approach, we start off with one inhaler, we then may introduce a different inhaler, we then might start adding in tablets and other inhalers, and suddenly your patient has 4 or 5 different medications they need to pick up every month. That's very, very costly if you haven't got a prepayment certificate. So do talk about things like prepayment. Intentional poor adherence. Well, we looked at this earlier on, but we will look at it in more detail now. This is the perception that treatment is not necessary, or the denial or anger about having a chronic disease like asthma, or its treatment. Patients may have inappropriate expectations, particularly when they first start treatment. They may expect their inhaled corticosteroid to work within a few hours or days. And this is where it's important that we discuss these treatments with our patients and tell them what realistic expectations of this treatment is. Advising the patient that it may take a number of weeks before they notice a significant improvement in their symptoms will help them understand that they need to continue with this treatment. Patients and families, parents may have concerns about side effects, and these may be real or perceived beliefs. And again, this is where talking to patients early on about what the side effects may be and how they can limit the side effects can help patients understand their treatment better and improve adherence. The patient may just not like the healthcare providers or may feel that they've not been given adequate time to discuss their health and their health beliefs, and this can definitely impact on adherence. Stigmatism is a real problem with asthma, particularly with children and young adults. They don't want to be seen to have to be taking treatment on a regular basis. They may feel that people are going to laugh at them or make them feel silly. Cultural or religious issues can also come into play with intentional poor adherence. It may be that they don't feel that it fits with their cultural or religious beliefs. And obviously cost comes into play in both unintentional and intentional poor adherence. So how can we identify poor adherence in clinical practice? Well, we need to start asking empathetic questions. Rather than telling patients what to do, we should try to acknowledge the likelihood of incomplete adherence. And I very often use myself as an example. I say to my patients, I'm a bit rubbish at taking my medication. Sometimes I forget. Do you ever forget to take your treatment? You're more likely to get a true answer back if the patient feels that you understand how difficult it is to take treatment on a regular basis. Asking questions like, do you find it easier to remember your inhaler in the morning or evening, may help decide which treatments that you might want to put your patient on. Before your patient comes in to see you for your consultation, check the medication usage. Check how often they've collected their prescription or ordered their prescription. This is where you can involve things like your local pharmacist, asking them, has the patient collected their medication, particularly if their medication goes direct to the pharmacy and they order it through the pharmacist rather than the GP practice themselves. Check the date and dose on the counter on the inhaler that they bring with them to clinic. Does this fit with how often they should have been using this particular inhaler? In some health systems, prescribing and dispensing frequency can be monitored electronically by clinicians and pharmacists. And as I've said, this is where involving the multidisciplinary team, getting to know your local pharmacist, can really help you, because they can highlight patients that are not collecting their prescriptions. So can person-centered care help? Well, we're going to look at person-centered care in more detail now. So what is person-centered care? Person-centeredness is a term that is becoming increasingly familiar within health and social care at a global level. It is being used to describe a standard of care that ensures the patient or the client is at the centre of the care that is delivered. So how can person-centered care help? Evidence increasingly demonstrates that adopting a person-centered approach for medication use that incorporates patient beliefs, preferences, goals and barriers to medication taking, for example the cost and the technological ability, concerns about medication prescribing and use, leads to better clinical outcomes. So let's step outside the world of healthcare just for a moment. So think about this. Do you have an iPhone? I certainly do. I wonder how I got hooked into iPhones. Do any of you have an old phone like a Nokia? Some may have old phones, but we tend to always want the next one that comes on the market. I wonder why that is. Why are we all so keen to keep updating our mobile phone? Apple's very good at it. Apple explained the features of the iPhone relating to the person rather than the device. So it sold the iPhone to people who loved music by telling them that they could store thousands and thousands of songs on the phone, and it would be available to the person using the phone within an instant, just a touch of a button. It sold its phone to people who love taking pictures. It told everybody that it had the best camera available. It also sold the phone to people who loved going on social media by telling everybody how good the iPhone was for using social media. And we got hooked. We all loved the iPhone. Imagine all of these people walking around the streets. I wonder how many of them have an iPhone. Wonder whether we needed to have an iPhone, or whether it was just the way it was sold to us that meant we decided we wanted an iPhone. Interestingly, I'm the only person in my family that actually has an iPhone. So although they're very good at selling, they don't sell to everybody. Why do we think that people don't all go with the same thing? How can we use this knowledge when we're looking at person-centered care? What can we do differently to improve person-centered care? We're going to have a look at that now. So how can we deliver person-centered care? It is important to consider the following in preparation for your consultation with the patient or carer or guardian. We need to understand what their values and beliefs are. Remember, the incidence of asthma is higher in children than in adults, so parents and carers or the guardians play a crucial role in the care for this patient or this child. So we need to understand what the parents or carers' beliefs are, as well as the child. We also need to consider what matters to this person currently. Now, we may be very well focused on ensuring this patient or carer or parent takes the medication on a regular basis. We as healthcare professionals are very focused on giving the patient the best care possible. but this may not necessarily be what matters to this person currently. The way we talk to our patient and the language we use can very much influence how we deliver this person-centered care. We need to show care and compassion. We need to understand what matters to the patient. We need to give them dignity and respect. And we need to coordinate and integrate our care. We need to remember that the information and education we deliver to this person is at the level they understand, and the amount of information that they want during this consultation that we're going to have. Overloading patients with information is not helpful. Picking key pieces of information that matter and are valuable to this consultation today is what makes this consultation person-centered care. Some examples of interventions that improved adherence are as follows. Shared decision making. Making inhaler reminders for missed doses, or being proactive through reminders and electronic trackers can help. And this can be particularly useful in the younger population who are very technologically motivated. So they like technology, they use a lot of technology on their phones. Having these reminders can help. And I'm sure my daughter won't mind me mentioning that she has a reminder to remind her to take her contraceptive pill. It helps her remember to take her pill every day. She has a little alarm on her phone that bleeps, bleeps, bleeps and bleeps a little bit more until she either switches it off and takes her pill, or it just keeps ringing. Obviously, she can have the option of just taking it off and still not taking her pill, but it does help. And we can encourage our patients to do this with their asthma medication. We can ask them whether they wanted to set reminders on their phone to take their treatment twice a day, for example. The other option is coupling medication regimes with everyday routines. And we do this quite a lot with inhaled corticosteroids. We advise the patient to put their inhaled corticosteroid medication next to their toothbrush so that before they brush their teeth, they take the medication. And again, using my son as an example, he takes his inhaled corticosteroid. He has asthma. He takes his inhaled corticosteroid before he brushes his teeth. It's next to the sink in the bathroom. This works well for him, but it may not work well for every patient. And again, working out a regime that works for your patient may be better. Another example is myself. I put my medication next to my bedside, on my bedside cabinet. I take it when I get up in the morning. It's there reminding me. I take it before I go to bed. It's reminding me. The problem is when your routine changes, you can then forget your medication. And again, this then leads to unintentional non-adherence. But at least adherence is better. The rate of adherence is higher. Obviously, you can use things like voice recognition programs, or even doing adherence education with your patient can all help improve adherence in asthma. I think the point at the bottom is very pertinent, particularly with the elderly who have multiple comorbidities, multiple medication regimes to remember. Trying to simplify that regime. Would a once daily treatment work better for this patient as they're already taking multiple medications? Can we make it simpler for our patient to help improve adherence? You can't do this on your own, however. You have lots of people around you that can help. It's a team effort. A team effort only works, however, if your team has the same values and beliefs as you do. And again, I'll give an example of this. Say there's 2 asthma nurses in your practice, so your patient may see 2 different people, or even a GP may be involved in this patient's care. And imagine if you all have different values and beliefs. There's many guidelines out there for asthma. There's GINA, There's BTS sign and there's nice. Imagine if all three of you had one guideline that you felt was better than the others, and suddenly you all have different views on what your patient should be taking. Now imagine if this patient starts off on one regime, goes back for a review, sees a different healthcare professional who has a different idea of what the patient should be on, and may say to the patient, "I don't believe that's the right treatment for you. Let's try this." Suddenly, the patient is confused. They don't know which inhaler, which tablet, which treatment regime they should be on. So as a team, even if you have different values and beliefs, you've got to have a regime that fits with every patient. If not, it gets very confusing for your patient. And the way you can do this is to look at what your local guidelines suggest. What do your local medicines management guidelines suggest is the right treatment for your patient? As I've said, this may not be your values or your beliefs, but as long as it's evidence-based medicine and it's working for your practice, then do try to work alongside what everybody else believes and have a team approach rather than an individual approach to your patient care. Having good staff preparation for care delivery is really important. Making sure that you've looked in advance at what patients may need. Think about how you could have some training and education for your team so that everybody understands what the treatment regime could be. Could you organise some coffee or lunchtime education sessions that would improve the patient care your patient is getting? Skill mix. Look at your skill mix. What have you actually got within your team? Do any of your team need to develop their skills? If so, how could those team members improve their skills? Could you actually mentor the person that is new to the practice to ensure that they're delivering the care that is expected within your practice? Having an authentic leadership style. Leaders do not have to be managers. We can all lead. We lead by example. So can we lead by example to improve the asthma care our patients are getting, to help improve adherence? Planning the care prior to the patient coming to see you is really important, including any risks. What is your patient's risk of having a future asthma attack? Have a look what the guidelines suggest could lead to an increased risk for your patient. Have they had a recent admission? Are they non-adherent to their treatment? Are they picking up lots of salbutamol inhalers? All of these things increase your patient risk. And we need to look at this prior to seeing our patient so that we can discuss this risk with the patient to try and improve adherence. But remember, we need to make this patient-centered. So it's got to be about what's important to your patient. Quality assurance and innovation is really important. Are you delivering good quality care? And unlock that person-centered potential in everyone, not just in yourself. Again, leading by example and showing how you can do person-centered care within your practice can improve person-centered care for everybody. And have a culture of kindness. Be kind to people. You never know what day your colleagues or your patient may be having. The day may have started off with a cup of coffee spilt on the table, missed the bus because they had to clear up the coffee. Suddenly they're running behind and the day has already started off badly before they've even got into the practice. So when that person snaps at you, be kind. Think about what is going on that person's daily life. And this is the same with your patients. When they come in to see you, you do not know what's happened previously in that day or that week or that month that that patient is having. Is there a reason that they're not engaging with you today? Is there a reason they're not adhering to their treatment? Think of that culture of kindness. How can we try and help that patient have a better day, a better week, a better month? And we should all find time to reflect. reflect on our own practice, reflect on the team's practice. And again, could you do some reflection sessions within your team to look at how well you're delivering this person-centered care? Think of your mindfulness too. How do you need to look after your own mental health? Do you need to take time out yourself to think, to be mindful, to reflect? Team approach is so important. Don't forget your wider team. Who else can you involve within this care? Now, if it's a child, for example, could you involve the school? Who's involved with asthma within the school? Do you need to involve the school nurse? Is there other healthcare professionals involved in this child? Is there a health visitor that's regularly seeing this family? Could they help support this child's care? And don't forget your pharmacists. Your pharmacists are so important. They can help with inhaler technique, ensuring the patient knows how to take their treatment and when to take it. Can you ask your local pharmacist to intervene with a patient that you're particularly concerned about? Use that wider team to your advantage. They're there to help you. They're there to work with you. How can your GP, who's regularly seeing this patient for something else, be involved in their care? How can they help with the non-adherence in asthma, for example? Use that wider team. They can help. Team approach. Identify the members of that multidisciplinary team that can support you. Who have you got around you to help you? We're going to look at a case study now, and this is lovely Ethel. Ethel is 73 years old. She has had asthma since her early teens. She has had poor control on and off over the years, and this was worse when she was pregnant. She has rheumatoid arthritis affecting her hands. Ethel attends for her annual review, and you discover she's struggling to use her inhalers. She is upset as she can no longer walk to the local shop to fetch her newspaper, as she is too short of breath. She is using her salbutamol every time she tries to exercise, so every time she tries to go out to the shop, she's reaching for her blue inhaler because she's short of breath. Her current medications are standard beclomethasone, 2 puffs twice daily using a large volume spacer and a PMDI. She was changed 6 months ago from a dry powder inhaler, which she'd been on for many years. She has a breath-actuated salbutamol, 2 puffs as needed, using many times a day, and because it's a breath-actuated salbutamol inhaler, she can't use a spacer with it. She's already on Montelukast, and she's on ibuprofen for her arthritis as well as paracetamol. Now I want you to think here about what matters to Ethel compared to what matters to the healthcare professional. Now, from a healthcare professional point of view, we want Ethel to have good asthma control. We want her to take her inhalers twice a day regularly. We want that SABA use to be less because we know that SABA increases her risk of having a fatal asthma attack. But is that really what Ethel wants? Do you think Ethel's bothered about taking her brown inhaler twice a day? Do you think Ethel's bothered about the fact that she's using her blue inhaler every day? That's not what matters to Ethel. What matters to Ethel is that she wants to be able to fetch her newspaper. And this is what we call patient-centered care. So we've no longer moved away thinking about what clinically we need to do for Ethel. We've moved away to thinking about what matters to Ethel. And what matters to Ethel is that she can fetch her newspaper. Now, obviously, we need to get her good asthma control so that she's well enough to fetch her newspaper, but that's not how Ethel sees it. Ethel sees it as her need to fetch her paper, her need to keep her independence is what matters. So when we're having this conversation with Ethel, we need to change the way we think about how we talk to Ethel. We need to say, okay, Ethel, how can we ensure that you can get your newspaper? So we need to go back. And Karl Bard says, although no one can go back and make a brand new start, anyone can start from now and make a brand new ending. And I think this is very pertinent for Ethel. What can we do here to give Ethel a brand new ending? And obviously we need to talk to Ethel and look about why she can't use those inhalers. And I'm sure any healthcare professional who was listening to this and who saw that slide where she had a large volume spacer and PMDI would automatically be thinking, we need to change Ethel's device here to a device that she can use. Now, obviously, we're all very conscious of the planet and we're all conscious of trying to be a greener provider or a greener prescriber. So perhaps this is a good time to think about a dry powder device that has a low carbon footprint. If you're thinking of this and you're thinking, okay, I'm going to put Ethel back on a dry powder device, the important thing here is to think, is this what Ethel wants? Is Ethel happy with a dry powder device? Why was it changed in the first place? Was it changed because the healthcare professional thought that the dry powder device was no longer appropriate for Ethel? Or was it just changed because somebody thought, she's on a PMDI for her salbutamol, let's put her on a PMDI for her ICS? Sit and ask Ethel what she wants. Show her some devices. Show her how they work. Ask her, which one of these devices, Ethel, do you think you would like to use to try and improve your asthma control so that you can fetch your newspaper? This is how we should be talking to Ethel. Now, I'm a healthcare professional. I work in a large teaching hospital. I have a number of nurses that I look after who see my patients regularly, and I say to them, what I want you to do is try and remember one thing about each patient, just one little thing that matters to the patient. It may be that they've got young children starting school. It may be that they have a dog that they look after. It may be that they like going on cruises. But remembering one thing about each patient and starting your conversation off with that one thing suddenly changes this whole consultation. It's no longer about you as the healthcare professional and them as the patient. It's about you caring about this person because you've remembered that they've just been on their cruise, or you've remembered that they've got a new puppy, or you've remembered that the children have just started school, and suddenly they think you care. They think you care about them because you've remembered one individual thing about that person. And for that 20-30 minute consultation, make that person the most important person for your day, because then you will have person-centered care, you will have engagement, and your patient is more likely to take on board what you are recommending, advising to them regarding their ongoing treatment. It's really, really important that we get to know our patients and remember just one little thing that can make that whole consultation very, very different. Thank you for listening to this lecture on person-centered care. I do hope you found it useful. I try to practice person-centered care on a day-to-day basis if I can. If you want to find out more, you can find out more about the courses that Education for Health offer by going to www.educationforhealth.org. There are a number of courses available on asthma that you may be interested in, or in fact, lots of other long-term health conditions that you may be interested in. or your colleagues might be interested in. You may also want to look at some of the work that Professor Rob Horne's done at the University College of London on patient-centered care. It's really interesting, and the web links are included on the slides. Thank you very much for listening. These are the references that you may find useful, and you may be able to look at some of the work that's been done around patient-centered care here.